the most common clinical response to a person who has suicidal thoughts is to get in medicine. And medicine doesn't really help that much. 130 Americans will die this evening by midnight by suicide. About 50 of them will be depressed. And there are, of course, millions of Americans who are depressed and never have a trace of a suicidal thought. It's a bad idea to kill yourself when you're suicidal. You can always kill yourself later. Wouldn't it be better on your dying day to know that you turned over every stone?
The single best thing someone can do is ask, are you feeling suicidal? Are you having thoughts about hurting yourself, taking your own life?
There's nothing more protective than that we can literally do than make the environment more secure.
Dave, that question has been probably the single most important question I've ever asked someone who is suicidal. If I can solve this problem, then I think I can save a life here. I'm psychologist Dr. Ali Mattu. Along with suicide prevention expert Dr. David Jobs, in this video you're going to learn the exact words to say if you're concerned someone might be suicidal. You'll learn what to secure at home to reduce suicidal risk, what actually helps reduce suicidal thinking, why suicidal thoughts aren't just depression, and how to grieve without blame. It's a practical, compassionate, and evidence-based conversation. Everything is time-stamped so you can jump to exactly what you need most. Now, I recorded this 2 years ago, so yes, I look a bit different. Perfectionism kept me from sharing this video with you. I'm glad you're seeing it now because what's inside might help you save a life today. If you're experiencing suicidal thoughts or worried about someone who might be suicidal in the United States, call or text 988. International helplines are linked below. The topic of suicide is one that people, not only clients and patients, but also therapists, clinicians, researchers, it's a topic people don't like talking about. And it's a topic that raises anxiety, and it's a topic that there's a lot of unknowns out there. So I just want to get started and ask you, how the heck did you decide to dedicate your career to this?
I got into this, Ali, by I kind of backed my way into it. I had a less than stellar college career, realized I wanted to become a clinical psychologist, and then realized I didn't do the things that are required to become a clinical psychologist when I was in college. And so I snuck into a master's program at American University and needed to really do the research to kind of get me, you might recall, through the hoop or over the hurdle to be competitive for these highly competitive PhD programs. And my psychopathology professor was a guy named Dr. Lanny Berman, and he was really interesting to me, and he was doing work in suicide prevention, which I didn't have a particular draw to. But I, sort of connected with him, and we started doing research on something called psychological autopsies, which is looking at the intentionality behind people whose lives end very suddenly. Is that an accidental death, or is that a intended death? And that's what I ended up doing my master's thesis and my doctoral dissertation on, was focusing on psychoautopsies and psychological backgrounds for people who are in these states. And so it was really a pragmatic thing. And then when I started getting into it, I realized this is just like a really cool topic because, well, I suppose at face value, it seems morbid or sort of like aversive topic. Yeah. My attitude is we're saving lives, and we're really focused on what makes life worth living. So a whole new line of research that I'm looking at, for example, in our lab, is once we've gotten somebody not to be suicidal, which we're pretty good at doing in the intervention that has been developed in my lab, how do they leave suicide behind? And so that gets into a discussion about purpose and meaning and what makes life worth living. Marsha Linehan was one of my mentors in research, and she's the developer of a very prominent intervention called dialectical behavior therapy. And she rolled out this idea of the importance of a life worth living. And we're now studying that and what sort of makes that go round. So 40 years in, I'm passionate about this because we're really making a difference in the world, and the difference actually is a life and death one. And as you said, there's a lot of clinicians who are just terrified of this topic, and we'll just get rid of these patients by putting them in the hospital. And that's probably not helpful in most cases. There may be some exceptions. But I would argue that the most common clinical response to a person who has suicidal thoughts is to give them medicine. And medicine doesn't really help that much. In this case, with ideation and behavior, and hospitalizations, which are very brief and probably, depending on the more harm than good, frankly, because there's not enough suicide-focused care, which is sort of my focus.
You started to study in your master's program under this professor psych autopsies and understanding what happened. It seems like at some point you developed this passion and this understanding for this. What was that process like as you were starting to develop this understanding of why people die and whether it was an intentional act or not?
I started working in a medical examiner's office at Walter Reed National Military Medical Center. So it was the medical examiner's office for the military. And they were, these are the folks that in the military would certify manner of death, which is natural accident, homicide, or suicide, or undetermined death. And at the time, there was a lot of debate around psychological intent and suicide. And so I did a very simple study for my master's thesis with case studies of equivocal deaths where the intent was not quite clear, and we manipulated the presence or absence of psychological information. And lo and behold, when they had the psychological information, it completely changed how they certified the death.
So it seems like in that time, people were not factoring in this information when they were understanding someone's death, which makes me think in that time, we had a very poor understanding of suicide rates. Is that fair to say?
That's fair. There were medical examiners back in those days that would only certify a suicide if there was a suicide note, and that occurs about 20% of the time. So there was a number of deaths by suicide that were not even counted because those medical examiners in that jurisdiction, without a note, would call it either an accident or undetermined death.
Wow.
So yeah, and it really does matter. I'm in D.C. and you were here for a while. I mean, I'm the chairman of the Public Policy Committee for the American Foundation for Suicide Prevention. We're on the Hill. We do a forum. We advocate for mental health policy and suicide prevention work. And policy does change things dramatically. Like 988, for example, is a major policy initiative that's transforming the country.
Which
in
is
terms of
the national hotline for
the national lifeline. Yeah, so it's the suicide and crisis lifeline is now a 3-digit number, and that piece of legislation had a 2% chance of passing under the previous administration, and it did. And now we're seeing a huge ripple effect, Ali, of people having to figure out when do I call 911 and when do I call 988 and what is 988 and what's a mental health emergency versus a crime. But that's a huge example of how policy can really make big change happen in a very short period of time.
Well, I imagine there's not going to be much funding into this type of research about suicide, suicidality, and treatments and suicide prevention if you don't have the data backing up the seriousness and the gravity and how widespread this problem can be. I also... It seems so silly to think about only classifying a death as a suicide if there's a suicide note. You know the research, but my guess is the vast majority of people don't leave any type of note. Or is that true, or am I just kind of making that up, Dave?
Yeah, 20% do, 80% don't. So it's the outlier. And yes, I mean, this is a field that's come into its own. I would say in the last 5 to 10 years. And now a lot of funding, for example, at the NIMH has been shifting over to suicide-focused research. And with 988, there's a lot of federal dollars being spent to kind of reimagine the crisis space and how we do crisis response. So yeah, I mean, it takes a while for something to catch on, and this field has been lagging for years, for decades. The suicide rate has just steadily gone up, while other leading causes of death have gone down. And it's not just the money, but there's also a maturity of the field, and this field is now matured and is a full-blown, exploding area where students are really eager to get into this and do this kind of research.
So you said changing norms, and you also mentioned when to call 911 and when is something a crime versus a mental health emergency. I'd love to get your perspective on the changing norms and how we even describe a suicide. So a lot of people will still say committed suicide versus died by suicide. And I'd love to get your thoughts on that, Dave, the history of where this term committed suicide comes from and why we might not want to use that.
Yeah,
terminology.
I mean, there's a medieval history to this, where for many years, for thousands of years, we understood mental illness or behaviors that were aberrant as possessions. The devil or demons or spirits invade the body, and that's why people act bizarrely. And then, around the Enlightenment period, there was a sort of a shift in thinking of it as more of a medical problem. But it was all wrapped up in like God gives us life. If you take your life, it's a sin against God. And there were even laws in Europe where people made suicide attempts, they were put to death as punishment.
That
A little
sounds.
ironic. But it was
I
seen
did
as
not know that.
as a crime against the state or a crime against the king. So
Wow.
So there's this lineage that really is troubling, and in many ways it haunts us to the present day, where the Latin is non compos mentis, not of one's right mind. They're sort of out of control. They're a lunatic, and if they came into the right mind, they of course would want to kill themselves. And so it became this medical model that evolved into the state being responsible or society being responsible to control this person. And so the idea of committing someone against their will occurs right to the present day. And I actually have a lot of problems with that model. Last patient I hospitalized was probably 20 years ago. And I've never committed a patient to an institution against their will. And I think to me, it's a huge idea that you would uphold someone's civil liberties and lock them up against their will. And now there's evidence that it's actually not helpful and may be harmful to do so. But it's a holdover, Ali, of a earlier time where the state felt compelled to control this person's behavior. And my intervention and the research that we do is trying to keep somebody out of the hospital and to work with them safely on an outpatient basis, and to really not use the medical model where you think of this person as a depressed person with a symptom of suicide. And what the research that I do and others have done in the field clearly shows is that when you focus on suicide ideation behavior as the bullseye of your treatment, no matter what the diagnosis or mental disorder, that's where the action is in terms of recovery and really helping someone.
So it was really seen as a crime. So committing murder, committing suicide,
Yeah.
these were pretty much on the same.
It criminalizes it. So really committing suicide is a vestige of perceiving it as a crime against God,
Yeah.
or against
How
the
should
state.
how should people talk about it if someone has lost a loved one, a friend to suicide? How should we explain that to other people? How should we share that?
The language that we would recommend in the field is, that they died by suicide, and that they suffered in such a way that they couldn't see an alternative. And that's really hard because there are people left behind.
Yeah.
And the people left behind always feel responsible without exception.
Yeah.
They'll always feel like they could have or should have done something that would have made the difference.
Yeah.
And no one's immune to that. I mean, that's one of the most awful things about suicide is that it implicates other people in a horrific way.
Yeah.
And a lot of times the decedent, the person who took their life, there's this thing we call perceived burdensomeness that they'll be better off without me. I'm such a problem in my family's life, in my marriage, for my kids, that it's my suicide will be a gift for them.
Yeah.
And it rarely, in my experience, rarely ever is experienced as a gift. It's usually experienced as a tremendous, irreparable loss.
Yeah, I mean that's something I want to talk about. I lost my brother to suicide. It's something that I've spoken a lot about on my YouTube channel. So I want to talk to you about survivors of suicide in a little bit. But I'm going to ask you an impossible question, and I'm interested to see how you might respond to it. So, can you paint a picture for us about what is happening in the mind, or also in the environment, in the life of someone who is actively suicidal, a typical patient of yours that might come into the office? What
Yeah.
what is going on?
Yeah. I think there's no one universal description, but in general, Ali, I think we would say this person is struggling and they're suffering. And as you know, in the research and work that you've done in your own career, some people struggle and they pull their hair out, and some people struggle and they act out sexually.
Yeah.
There's a subset of people who struggle and say, "I should kill myself," or they start to think, what would it be like if I ended my suffering in this way? And so it's a bit of a relationship. That's how I oftentimes have thought of it, is that that a relationship with an option for coping that becomes seductive. And I don't mean sexually. I mean just in terms of the concept that it will solve all my problems. I'll unburden my family. My pain will end. They'll get the life insurance. There's a kind of a logic to it, and people start down a trail. Now, what's so interesting about it is how many people don't go this way. Which is why the idea of depression and suicide being synonymous is so completely and utterly not true. You have 130 Americans will die this evening by midnight by suicide. About 50 of them will be depressed, clinically depressed. And there are, of course, millions of Americans who are depressed and never have a trace of a suicidal thought. So it's a very particular kind of suffering that we're talking about.
Yeah.
And in the mind,
And so one that is not necessarily tied to depression, because I think that's a huge myth a lot of
it is.
people hold on to.
It's not there, but it's not synonymous. Like
Yeah.
in Minnesota, there used to be a billboard: "Depression kills," and that's just so not true. I mean, there are millions who are depressed who are not going to die by suicide. So it's a kind of suffering that's particular to this way of coping that people get sort of in their mind's eye, and it takes on a life of its own, so to speak, and they get captivated by it.
So it seems like there's many different pathways then to this way of thinking. I mean, I've worked with people who had OCD
Yeah.
and were reaching a point where they had it for so long, it was so overwhelming, and had consumed so much of their life that now suicide seemed like a good option for them.
Yeah.
And again, no depression there. I've worked with people who have it was they were doing just fine, and then they had too much alcohol one night,
Yeah.
and attempted to take their lives, and wake up still alive and wondering what happened, how did I get from there to here. So what are some of these pathways that might lead someone to this way of thinking?
Again, many and varied, but a lot of the pathways implicate intervention. So you mentioned alcohol. People that are picked up for a DUI and may attempt suicide or take their lives in lockup. It's a circumstance that they find themselves in where their life is over, or as they see it, they're impaired, and they might think, I'll never get over this.
Yeah.
So lethal means safety is a big focus in the intervention space around, especially access to firearms, because they're number one in our country for the method choice. So there are circumstances that come together. Ed Schneidman used to talk about like the perfect storm of how pain and stress and agitation kind of converge in a moment to spark a behavior. And so a lot of us think that psychological pain is pretty much a key ingredient, and then hopelessness comes into the mix, and then and you say it's a bad idea to kill yourself when you're suicidal. And what he means is you're not thinking cognitively flexibly. You may be sort of limbically dysregulated and upset, and your prefrontal cortex and frontal lobe are not as engaged as we would otherwise want them to be. So so there's a biology to this. There's genetics to all this, but a lot of it is just unbearable psychological pain, access to lethal means, a constriction in thinking, lack of problem solving, lack of being able to find your way through a difficult time. A lot of the young people that we study. So we've got 3 clinical trials right now with young people, including teenagers. And a lot of them are caught up in, and again, I'm saying this descriptively, they're caught up in the drama of suicide, that this is something they connect with others around. It becomes kind of a way that they know themselves, and they find comfort in it. And so there's just a lot of different pathways, but a lot of it is rooted in pain, and a lot of it is a kind of problem solving that has a dead end.
So it seems like people are in a situation where they're suffering
Yeah.
in a way that their ability to deal with that suffering
Is overrun.
It's not working anymore.
Right.
And if all of these different pieces come into play, then they might be really at risk. There's one time in my life where I did feel briefly suicidal. It was actually when I was in grad school, and fortunately, I had a good therapist. But what was happening is I had these 2 dissertations. I had the first that didn't really do so well. I'd been working on it for, 9 months or so. There was a deadline coming up. It became pretty clear to my advisor and I that I wouldn't meet that deadline.
I remember Ali.
Yeah. I started crying in her office. I felt like everything was falling apart. And then I started to question, am I ever going to get out of grad school? Is this it?
Yeah.
Is it over for me? And that was the first time where I had these thoughts of like, well, maybe it'd be better if I'm not here. Now, those thoughts didn't last that long.
Yeah.
But they were there for that day, and it was where my stress was really high. I was feeling hopeless.
Yeah.
I also, Dave, I don't think I had been sleeping well for a while.
Yeah.
So it felt like this other state of consciousness where my brain wasn't working well.
Right.
It didn't last long because I had a really good advisor, and I had a good therapist, and I had a partner who was very supportive. So those pieces sort of brought me back, and I had lost a brother to suicide, and didn't want to do that to anyone else. Didn't want anyone else to feel the guilt and suffering that I went through as a result of losing him and how much I miss him.
Yeah.
But I do remember that day and how strange my thinking was and how scary that was in that moment.
Well, and that's the kind of thing that happens where people just keep going. So you had good supports, you had people who cared about you and reached out to you, and you were taking care of yourself as well. But lack of sleep, if any of us don't sleep for several nights or get REM sleep in particular, that rapid eye movement sleep associated with dreaming, we get really agitated.
Yeah.
And agitated, dysregulated states where we feel out of control, where this part of the brain, right in the center, where the limbic system, which is the sort of the more older part of the brain, is on fire, and we're in a fight or flight mode. That typically means that this part of the brain, which is the quarterback of the brain, is not engaged. So a lot of the interventions, Ali, involve helping a person recognize that they're getting in trouble, that they're becoming dysregulated, and then doing things that's going to re-engage this part of the brain to down-regulate this part of the brain that's kind of on fire and out of control. So you're describing a version of how interventions work, and maybe not in your case, but I mean that's how our intervention works. It teaches our friend Stephen O'Connor, he went to grad school with, talked about effective intervention involves making the patient their own suicidologist. And I've always quoted that and used that idea because I think that's really true in all the proven interventions, including our own. Teach the patient, I'm getting in trouble. I should do X, Y, and Z to get out of trouble.
So before we talk about interventions, one of the questions I get a lot is, what are the signs? How do I know if a friend, a family member, if they need more support, if they're, the term that keeps coming up is at risk, if they're at risk for this. Hearing you describe this, and also just reflecting back on that one day I had, it seems like it's difficult to know if someone might be entering a suicidal thinking, a period of suicidal thinking. Yeah. And I'm sure there's another question I got in advance of this, of recording this, is people who might be chronically at risk or chronically thinking suicidally. So much of the conversation around suicide is about a crisis.
Yeah.
This episodic thing. The example I gave was like that too, but there's a lot of people who live with this type of thinking and it's sort of constantly in the background. So can we talk about this for a moment? What friends, family, loved ones, what do we do? How can we know if someone might be experiencing this and struggling with this?
I mean, the biggest thing is to ask. And that seems like the impossible thing, or that you're going to plant a seed or something horrible is going to come from that. But to ask someone that you care about, the biggest thing that I suffer with in people I see who've lost someone to suicide is that they wish they had done X, Y, and Z. That they'd asked, that they knew something was not up, it was up, and things weren't great, but they were afraid to ask, and they have many, many regrets. So I'll get a lot of people coming to me in my practice saying, I'm very concerned about my son who's 32 and he won't seek treatment and he doesn't talk to us, but we think he's suicidal. What can we do? And what I would have them do is make a I call it coping care package. I would have them make literally a package, put in a book called Choosing to Live, written by Tom Ellis and Corey Newman, that's written for people who are suicidal, and put in resources and put in letters of love and concern, and then give that to that person so that they physically gave them something that would perhaps get the attention of this person who's struggling. But you can't make somebody, who's adamant against getting treatment, make them get treatment. And I'm not a fan of mandated treatments or court ordered treatments because it just doesn't work, and the literature is clear on that. So, and now this woman, Stacy Friedenthal, who's a professor at University of Denver, has written a book for people. It's by Harbinger Press. I wrote the foreword for it. It's called Caring for Someone Who's Suicidal. And she's just got, item after item of things to do, what to say, what not to say, what to do, what the resources are, what do we know. It's a beautifully written book for people that are concerned about people who are suicidal. Yeah. So I can't recommend that enough. But the ideas are sound in terms of being direct about it, not avoiding the topic. Honestly, securing the home. If firearms are available, secure those firearms, lock them up. So there are very concrete things that can be done both environmentally and then interpersonally with that person to intervene. And I really, and then the hard part is, and this is really hard, is that the common response is to put somebody on medication, and or have them admitted to a hospital or taken to the emergency department. And all three of those common responses are not necessarily helpful, and sometimes they're unhelpful. And when I talk to journalists, and when I talk to people in the field, and when I talk to patients and families, they can't believe that a hospitalization of 3 days or 5 days or 6 days this is my magical thinking, is not somehow miraculously going to make them better when what they typically get is medication, which doesn't really work for suicide risk. They go to a couple of groups that they don't find especially helpful, and they sit in the day room and watch a lot of TV.
Yeah.
And,
Yeah.
I hate to be, Debbie Downer, but I mean, hospitalizations, with exceptions, are mostly not that helpful. And you've now removed this person from their home, from their family, from school, from work, and now they're officially a crazy person because they got hospitalized in a psychiatric unit. Now, mind you, you can do interventions that actually are effective. We just published a paper in Germany about our intervention as an inpatient experience where we showed after discharge, suicide attempts were dropped in comparison to controlled treatment. So that hospitalization could be made more effective, but the modal common experience of hospitalization and use of medicines is not effective. And people can't believe it, but it's true.
Yeah. Yeah. Well, I mean, in most areas of healthcare, the idea of being admitted to a hospital implies a higher level of care that is going to stop the bleeding, metaphorically and literally. And my experience working at my internship, I was at Bellevue Hospital,
Yeah.
the oldest hospital in the country and well known for
Yeah.
its psychiatric care.
Yep.
There is a lot of diversity related to what happens in inpatient units, what happens in emergency rooms, and my experience then working at as faculty at Columbia and having people admitted and seeing a lot of people that were coming out of inpatient admissions, a lot of diversity in terms of what people get, which is, I think, a nice way of saying some people get exactly what you're talking about, which is you're in a hospital room watching a lot of TV, people are staring at you to make sure you're not doing anything to harm yourself, versus real effective treatment protocols being integrated into that inpatient experience. Most people assume that a hospital experience is going to be providing more effective care than some of the things that you and I have witnessed.
Well, I would say the latter is the outlier. There
Yeah,
are
I agree.
places where people get decent care, but the modal experience is very minimal, and they're mostly about getting people out the door. So I went to a prominent hospital here in Washington, and went on an inpatient unit, and did a demonstration of my intervention in a one session version of it. And the medical director played the patient that they had just discharged a previous week or two ago. And I did my thing, and I'm pretty good at this. I've done it for a long time. And so we developed a stabilization plan, and we developed a treatment plan. And in my intervention, we asked people what makes them suicidal, and that's what we treat. Crazy notion, but we treat the things that the patient says make them want to kill themselves. And after that role play demonstration was over, an attending in the front row said, "I have a big problem with what you just did." I said, "Oh, really?" And she said, "Yeah, you sold him a bill of goods." I said, "I don't think so. What exactly?" "Well, you promised him all kinds of things that we can't deliver." I said, "I'd refer him to vocational rehab, and would try to get his son to come into the unit before he was discharged to try to reconcile that relationship." And I clearly said, I'm not promising on either of these. And so, "Well, we don't have time to do that." I said, "What do you have time to do?" It was a very awkward moment, because what they do is that utilization review person comes up and shows on the unit and says, "Oh, yep, this person's been here for 4 days. Nursing staff, get them to commit to their safety and get them out the door."
Yeah.
And they may not get a safety plan. There may be no discussion if there's a firearm in the home that they're going back to. They're given a script for medication, and medicine doesn't typically help with suicidal ideation and behavior. So I'm up for changes. I mean, we have a colleague in Louisiana at LSU who does an inpatient version of our intervention, one session, and he's getting a really nice effect. And a lot of these patients are committed against their will. So it doesn't have to be an extensive intervention, but it does have to be suicide focused. and it does have to involve some specifics around lethal means. And what's this person going to do instead? I mean, one of the crazy things that you may have experienced, which is still done today, is getting somebody to say, promise me you'll kill yourself between now and Friday.
Yeah.
Sign this no harm contract.
Right.
As if that's an effective thing.
Right.
Whereas
it might not even be effective at reducing legal liability, which is why
it's going to increase your liability because the remedy is a safety plan or a stabilization plan, which talks about what you will do versus what you won't do.
Yeah.
But there are still people that use no harm contracts despite that, and we have data now, randomized controlled trials, showing that no harm contracts, no suicide contracts don't work.
Yeah.
And yet they're widely used.
It must feel like on the other end of a client, it must feel like here's another way in which I'm losing control. Here's another way in which I'm trying to be, someone is trying to control me, restrict me.
They are. And they're invalidating you. They're coercing you. They're bossing you around, and they're intimidating you into saying what they want you to say so they can write down the chart thinking that's protective from malpractice.
You've mentioned firearms a lot.
Yeah.
And there are a lot of methods that people might use to kill themselves, but you're mentioning the importance of, in some situations, you want to make the home safer. Now, there seems to be an implication there that we can save lives if we temporarily reduce access to things that people can use to hurt themselves. Which implies, Dave, that it applies a lot for public policy. I mean, I live in San Francisco Bay Area, and the Golden Gate Bridge is something we could talk about, and the long debate about putting some type of barriers there, since it's the world's, I don't know if it still is, but for a long time it was the world's #1 destination for ways of dying by suicide, jumping off that bridge. There's public policy implications here that we should create a world that's a little bit safer for people, but there's also real implications for friends and family. And at the heart of that is also this loss of control.
Yeah.
So can you help me understand and negotiate these things? That are you saying that that this could be a temporary state of risk, and during this temporary time, we need to make the environment safer so you don't impulsively act on a thought? This is something you and I talked a lot about in your class, so I just want to revisit it and get your thoughts on this.
Yeah, this is probably the single best way we can prevent a suicide from happening, is making it less possible, less likely. And whether that's securing stashes of medicines, opioids that have been unused and so forth, and locking those up or getting rid of them. Or there's evidence of places where people jump, where they put up a barrier and people don't jump. And there's something that we call method substitution. There's no method substitution. So if you block one method, it doesn't mean that they'll just go ahead and do something else. It actually stops that suicide. But guns are #1. And so there's a lot of us in the policy field who are trying to work with gun owners, firearm owners. There's actually research that shows that firearm is less of a turnoff for people that own them than the term gun. So that we used to call restricting lethal means, and now we talk about lethal means safety, because people are doing research now, Ali, on the language of all this. And lethal means safety is a less threatening idea. We have now something called red flag laws, where in certain jurisdictions, in certain states, if a family member is concerned about their brother, they can contact the police, and through a certain procedure, that gun can be removed for a period of time from that individual's home and returned when they're more stable. Which is literally the state taking your gun. But these laws are passing. And as with all the school shootings that we're seeing in the mass murders and the AR-15s situations, this is a hotly debated, politicized issue. But there's nothing more protective than that we can literally do than make the environment more secure. We have an NIMH-funded clinical trial with teenagers, and the initial engagement is with the parents, where we develop a stabilization support plan. And the whole first page is about creating a safer environment. We then do the intervention with the child, and then we bring the parents in the back end. And the second page of the stabilization support plan is how are you going to support and love your child differently better. And we're studying this right now, and it's working really well because it gives parents a very clear role to make sure the home is secure and to support the treatment. And the clinician is saying, I've got the suicide piece,
Yeah.
and I'm going to do the suicide piece with your child. And a lot of parents, you can just see, they're so relieved to see a clinician say, I've got this. And here's what you do, and here's what I'm doing.
Making the home safe. You mentioned before that the single best thing someone can do is ask. Are you feeling suicidal? Are you having thoughts about hurting yourself, taking your own life? And that is something that also doesn't put the idea of suicide in someone's head.
No, there's 4 different studies showing that that's not the case. So
Yeah.
it's not, the seed planting idea is not supported by the data.
So sounds like making the home safe starts with that, is having conversations. If you're worried about someone expressing that concern and then showing your love, what did you call it? It wasn't called a hope kit. It was called what was it called?
Stabilization support plan?
Yeah, you talked about creating
coping
this
care
box.
package. Coping care
Yeah.
package. Yeah.
Coping care package, and really showing all these tangible ways in how you love the other person. What else goes into making the home a safe place?
I think just anything that you can think of that could potentially, I hate to say it, but that could be potentially used for self-harm is made secure within reason.
Yeah.
So most families have to have knives in their kitchen, but I mean, depending on the situation, you might want to sort of stash those away within reason. But, car keys left out for a teenager to run off with the car and crash into a tree. I mean, ropes or cords that are just sitting around the garage. I mean, we will literally, in the stabilization support plan, literally go through every possible lethal means that never even occurred to you. I was in a forensic case years ago of a couple whose son shot himself with a gun that the parents bought during their honeymoon in the Caribbean that was sitting in a cedar chest in the back of their closet they had totally forgotten about. He found it, and he took his life with it. So, one of the things that clinicians can do is kind of walk the family or the parents or the spouse or the loved one through, have you thought about this? Have you thought about that? To make the home environment as secure as possible. And then clinically, what we do a lot of times is we'll put pictures, in the bathroom of your reasons for living on your mirror. So you see your favorite niece every morning when you get up. She's right there. So we'll do reminders and things like that. Or if somebody's thinking about using a car to crash in a tree, that they put a picture of their kids on their dashboard. I mean, things like that may seem silly, but they actually do make a difference.
I remember you sharing this line that you use, and I have used it so many times, Dave, in all of my work, which is before you make a permanent decision about your life when you are in this temporary state of risk, let's take some of these actions and give the treatment a chance to work.
Yeah.
You probably say it a lot better than I do, but it seems like that's also what we're talking about with the family here is we know you're struggling, we know you're suffering. Let's make the home a little bit safer temporarily to give all these things a chance to work before you make a permanent decision, because that decision is irreversible.
Yeah, I see it known for or infamous for saying to patients, you can always kill yourself later.
Yeah.
Which is true. But as a licensed provider, if you're going to talk to me about this topic, here's the DC Mental Health Act. Here's the line about clear and imminent danger. I would rather not hospitalize you. So in the spirit of informed consent, and you took ethics from me, you know about how important
I do.
informed consent is. In the spirit of informed consent, if you venture into the zone of clear and imminent danger, I have to stop you. That's a duty of mine within our jurisdiction. I would rather not do that. So here's the deal, that in my case, there's an intervention that I know that works in about 6 to 8 sessions, 12 on the outside, everything to gain, nothing to lose. You and I get to be dead forever. What's your hurry? Wouldn't it be better on your dying day to know that you turned over every stone? Wouldn't it be better to know that you tried a treatment that's proven to help people all around the world decrease their suffering in this way, than having not done that? Wouldn't it be tragic if you took your life before you knew whether this could work or not? And if you do that with love and sincerity and earnest regard, most people are like, yeah, I could try that. It rarely does it come down to an adversarial thing where I feel like I have to call the police. In fact, I don't. I mean, I just haven't done that ever.
Well, what you're describing, I mean, even hearing it, I've taken multiple courses with you. I know you personally, I know you professionally, I've known you for a long time, and a lot of the things that you say have become part of what I say. Despite all of that, Dave, what you just said, my initial reaction was, that's provocative. It kind of raised my blood pressure.
Yeah.
At the same time, it seemed very validating. Like you are speaking truth to the experience I'm having. And a lot of what I'm hearing in our conversation, and this is what I want this show to be all about, is a lot of this seems to be about speaking to the things that someone is experiencing, speaking to the things honestly, openly, about the suffering that they're experiencing.
Ali, when I was in grad school, I had this professor, and she was this older, infamous, famous woman in DC. Her name is Margaret Rioch, and she was very famous here in Washington. And she was a protege of Henry Stack Sullivan, and she founded Tavistock here in Washington. And we took the second year seminar with her, and she was probably in her 80s. And I remember this one session we had with her. She's like, "Oh, you young people, the importance of honesty and truth in psychotherapy is highly underrated." And we're all like, truth and honesty is important, And now, 30 years later, I think, it's all about the truth and honesty. Especially people who are thinking about taking their lives.
Well, going back to some of these classic therapists, like a Carl Rogers and humanism, so much of that was about being honestly present. Unconditional positive regard means you're truly listening, and you're truly reflecting back, and you are there with the person. And I also think about dialectical behavior therapy. You mentioned Marshall Linehan before. So much of the layers of validation that she's talked about is about getting to a place where you can be radically honest with someone else. And that's what I hope some of the people listening to this are also taking away, is one of the best things that you can do is to be honest about your fears and your concerns and your love for the people in your life.
Absolutely.
So, Dave, tell me about this treatment. I've been trained. I understand it. When you first explained this in the seminar on suicide that I took with you, it seemed so practical and almost like it just made too much sense. But so, can you explain to people who might not know what this treatment approach is how do you and your lab and everyone you've trained, how do you approach the mental health problem of suicide?
Well, we approach it based on the idea of a collaborative relationship. That person says that they're suicidal, and the clinician will say, "Well, you can't kill yourself," and this person will say, "Well, yes, I can," and the clinician will say, "Well, no, you can't," and all of a sudden you have something that we know doesn't work, which is an adversarial dynamic. So back at Catholic U, where you went to grad school and I teach, I worked in the counseling center where we developed an assessment tool called the suicide status form. And long story short, after different iterations and different experiences and research steps, we started administering this side by side. We would ask for permission to take a seat next to the patient, and we would go through this assessment tool together. And there's different
You
quantitative
physically move
Yeah.
and sit next to the person.
with the patient's permission,
Yeah.
which meant during the pandemic we had to make some adjustments. I can tell you about that.
Sure. Yeah. Yeah.
But the symbolism of getting on the same side of this and going through this tool together is intentional. And most patients, clients find that to be a very validating experience. And we're marching our way through this, and we get through a certain amount of assessment, and the patient a lot of times is surprised how much they're learning about their own struggle. And then we ask about some, the clinician takes over, but we still are sitting side by side. We're still going through the same tool together. To come to a treatment plan where I'll say, Ali, we've really now got a sense of what your struggle is about. I'd like to find a way to keep you out of the hospital. But to do that, we've got to develop a stabilization plan. Should you get into a acute dark moment, that's critical, and that will involve reducing access to lethal means and different problem-solving strategies, who you can reach out to, including me, or the crisis line. And then we're going to treat the two problems that you say make you want to take your life. Overwhelmingly, these are relational issues. A divorce, my kids don't talk to me, I'm isolated, I'll never get married, things that people are, it's relational issues in suicide are ubiquitous. It's
My parents don't understand me. I'm doing horribly at school. I'm ashamed.
Being bullied by kids online.
Yeah.
It's a relational phenomenon. And then what comes in second and third is issues of the self, like self-hatred, or issues of what I do. I'm a engineer, but I always want to be on Broadway. I don't know, where there's a vocational crisis. And the interesting thing about these, as is that these are treatable issues. These are not like to eradicate them, but we can move the needle on these problems in about 6 or 8 sessions. And in so doing, the person's looking at suicide when they first come in, and now they're looking at this way. And that shift is the therapy. So they can still have the thoughts, but they have learned to manage the thoughts, manage the feelings, and they're behaviorally stable over the course of these sessions of CAMS, the Collaborative Assessment and Management of Suicidality. So the SSF is a multi-purpose tool. That's the roadmap. It's also the medical record. For clinicians who are worried about malpractice, it's the medical records that can protect you from litigation, and patients like it. So it ends up being a very empathic, validating, collaborative experience. The clinician is an active participant and partner. You get a copy of all these documents, so that's sort of the gist of it. And then we've done a bunch of clinical trials to prove it works.
I remember the first time I saw it, and how practical and helpful it was. The bottom of it, at least in the version I was trained in, reasons for living, reasons for dying.
Yeah.
And that final question on the bottom, the one thing that would help me to no longer feel suicidal is, in a blank. Dave, that question has been probably the single most important question I've ever asked someone who is suicidal. And it tells me exactly what I need to do to help this person. If I can solve this problem, then I think I can save a life here. It's just so practical. And to the people in mental health who are watching this, where can they learn more about this treatment approach? How can they learn more?
There's some people that can buy the Guilford book and just copy the forms and give it a go. And it's a shameless plug.
What's that book called?
Managing Suicidal Risk, a Collaborative Approach. Sold 47,000, which is not nothing, but it's a drop in the bucket when you think of 15,600,000 people with serious thoughts of suicide. It's a lot of people.
Yeah.
And CAMS treats ideation better than any other intervention. It doesn't always reduce the behavior. There are other interventions that reduce behavior, but it treats ideation and hopelessness better than any other intervention. And so they can
And
they're
ideation is, how would you define ideation? Ideation is
having
thinking.
ideation, thinking about killing yourself.
Yeah.
That,
Okay. Yep.
that suicide is a solution or an option for you.
What about the person who is chronically suicidal, for whom this is something that does appear to be in the back of their thoughts all the time?
Yeah. It's a great question, and for a lot of clinicians, sort of the one of the biggest challenges. What I would say is that that's a different kind of psychology. When people are first suicidal, suicide's like a bit of like a hot potato. They got it, but they kind of like when I get rid of it, and it's burning their hands. But over time, people come to feel differently, and the thoughts of suicide can be very comforting. It can be like a warm blanket that sort of gives me comfort because I know I can control my destiny, and this is something that's mine, and I don't want it taken away from me. And that's a different animal. And CAMS may not be as good for that kind of person. Something like dialectical behavior therapy might be better, or probably is certainly better, except for a subset of people like that, for whom the CAMS actually, we did a study in Denmark that showed that it was highly effective, but only for about 40% of that population. The other 60% did terrible. So there are subsets of populations that we study, and CAMS is good for people who are newer at being suicidal, and probably less so for chronic states. But DBT is really good for chronic states.
Yeah, and so that also makes sense to me. If someone might be experiencing these thoughts for a very long period of time, and their relationship to these thoughts have changed, they might
Yes.
need something like DBT that does tackle identity issues, emotion regulation, how you handle distress, your relationships with other people, something that might more comprehensively tackle the way their relationship to these thoughts have changed. That makes a lot of sense.
We're doing a line of research now, Ali, with people with lived experience.
Yeah.
So these are people who have been suicidal, made attempts, or are currently suicidal. And we're asking them about the idea of a post-suicidal life. And there's a subset of them that don't want to not be suicidal. They suicide is a part of their life. They're going to die by it. They might be doing quite well, but it's become a part of who they are. And it's been a fascinating line of qualitative research talking to folks like that about, I assumed that everybody wanted to get rid of suicide, but not a subset of people that we're talking to. And that's been a really interesting finding.
So one more question about treatment. You've worked with so many people who are suicidal or have been. You've also studied this. I'm just curious, and this was one of your first draws into this part of mental health, the mental health field.
Yeah.
What has all of this taught you about building a life worth living? Like working with all these folks, studying all these things. Where are you on that?
Probably one more book in me, maybe after I retire, about that topic. Because when you study this for 40 years, as you're suggesting, you really learn a lot about life. And you learn a lot about people who struggle living it and what they don't have and what people crave. And so I really feel like, Marcia sort of launched this idea of pursuing a life worth living and sort of a plenitude without really, in DBT, there's not really operationalized that. And what's interesting, I remember in our Army trial, a soldier, we watched videos for fidelity and adherence purposes. And the soldiers in this case knew that they were being video recorded. And there was a guy like, okay, got it. New mission, not kill myself. But my life is a dumpster fire. I'm totally screwed up. How am I supposed to live? And I remember it was like, oh, yeah, so just getting somebody not to be suicidal is a step, but doesn't carry the day.
Right.
In fact, one of the things that we've seen in research, you alluded to reasons for living, reasons for dying. There's a Swiss study that we did where we thought reasons for living was going to be really protective in 2 years follow-up. It didn't do anything. Because for patients in that first session, they're focused on dying. The clinicians are focused on reasons for living. It's a clinician variable, if that makes sense. So in CAMS, what we do is we bring in reasons for living later when there's been some traction. But what gives us purpose and meaning? That's really, to me, kind of the holy grail of it all. And what, to me, is pretty clear is that relationships, it sounds obvious or corny, but relationships is sort of like the big thing.
Yeah.
Romantic relationships, being a parent, being a brother, being a sister, co-workers, close friends. That's, to me, what seems to make the world go round. And then there's a lot around my own sense of purpose and meaning. What makes life worth living for me? That's very particular to me. And people, you know about this. You talk about this all the time. I mean, I love like the concept of grit, because people who are suicidal don't have it. They aren't perseverant, and they don't have a greater sense of purpose and meaning, a passion for making a difference in the world. A lot of what we're learning about Ali from talking with the lived experience folks is they have found a way to live by giving and making a positive difference in the world. And that's, whether that's through lectures or through writing or poetry. It's been striking to me that people who've been, what Marsha would say, been in suicidal hell and have survived that, they're very preoccupied with giving to others and making the world a better place.
So much of mental health seems to come back to these things: relationships, meaning, purpose, making a difference. Regardless of what we're treating, my clinical focus became treating anxiety, and the main motive, when it comes to anxiety, people don't just have anxiety problems and come in for treatment. People who have been struggling with these things tend to be struggling with them for years before they come in for treatment, which is no surprise. I mean, that's how a lot of mental health works. But the motivation for coming into treatment tends to be relational.
Yeah.
I worked with someone who spent their entire life in Manhattan, never left the island due to agoraphobia, this fear of situations where you can't escape, couldn't go through tunnels, bridges, things like that, and was very close to his grandmother, who lived in Queens, just across the bridge, and or through the subway. And the grandmother would always come visit him, and she couldn't do that anymore. And now he was in my office.
Yeah.
That's where the shift happened. So I think so much of this comes back to relationships. I want to talk about relationships for a moment. I lost my brother to suicide. A lot of this, this is very near and dear to my heart. I know it's near and dear to your heart as well. And what's the number around how many people are impacted by a death by suicide?
It's been increased significantly. It used to be thought it'd be 5 or 6, but now it's like 30.
Yeah.
In terms of people being meaningfully impacted by the loss of a loved one to suicide, or a close friend or something.
That seems to fit my experience with my brother's loss. So how and you mentioned guilt earlier, that this is such a powerful emotion. So much complicated grief comes out of this. What can we do to help friends, help families who have lost someone to suicide, knowing how different that grief process might be than other forms of grief?
Yeah, I just did a really interesting series with this Catholic group that wanted to, because Catholics are terrible with this. There's a lot of people think that they shouldn't be buried in a Catholic cemetery, that they're going to hell. Vatican II actually decriminalized all this, but a lot of people don't know that. So this one pastor, a deacon, lost his daughter, and he wanted to make a positive contribution. And so he interviewed me and Melinda Moore and some other people that are pretty knowledgeable. and talked about their stories. And what I said in that, which I always say, is to try to remember this person as how they lived and and what you loved about them, and not about how they died, which is not easy, but so much of the pain is the last conversation we had, what
Right.
I didn't say, what I didn't do. I think about our professor at Catholic who took his life, Tom Wright, close colleague and good friend for years. And I think about the 2 days before he took his life, he stopped by my doorway, and I was reading my email, and he ducked his head in. And I was like, "Hey, Tom," and he kind of lingered for a moment and said, "Are you okay?" And he just kind of left. And
Mm.
more times than not, I was, waved him in, and just like I did to him, and sit down and have a chat. But I didn't that day because I was too busy taking my emails. And 2 days later, he'd taken his life. So we all are, have these regrets or second thoughts, but this person was a whole person who was more than how they died. And that's something I always try to say is like, can you try to remember what you loved about this person that made them so special to you? And then the other thing I always, always say and try to live is, can you live as this person would have you live, and honor their memory in so doing? And if you know that your brother or, Tom or people that I've known and lost, I mean, we've lost 5 patients in clinical trials, and I've lost a patient when I was an intern at the VA. It is a wretched way to lose someone, mostly because you can't ask why. You'll never know exactly what was going on in their mind. It's just a horrific way to lose someone. But to me, the way that I can do what I can do is by having a mindset that I can do a lot. But I'm not this other person. I can never know for them what's best for them. I have my views and opinions, and this is true for my patients as well. But if they do pass in this way, I'm going to try to honor I'm going to try to honor their memory by how they would have me live and do what I do.
I remember learning about complicated grief after after I became a psychologist, after I became licensed. There was some training experience I went to, and I remember that person telling me, or telling the whole class there, that it takes about 5 years for people to get to a point where they're able to talk about a death that occurred due to some type of complicated grief. And complicated grief meaning there's a variety of emotions that are created: sadness, anger, confusion, guilt, all of these kind of things that you don't have as someone dies due to a medical illness or an accident, that kind of stuff. You mentioned mass shootings before. I think that's also an area where there's a lot of complicated
Yeah.
grief that occurs. And just knowing that really helped me, because it was about 5 years before I was able to talk about it more. My wife talks about that time period where it was like walking on eggshells. She didn't know what would set me off.
Yeah.
And it's because if there's a TV show or another person and they say something like, "Oh man, it makes me so angry, I just want to like shoot myself," it would be so overwhelming for me, Dave,
Yeah.
because it
Yeah.
would take me back to finding out about my brother's death. It would
Yeah.
reawaken all that grief, all those emotions.
Yeah.
So it took me years to get to a place where I could learn to regulate my emotions again, so I could
Yeah.
even be present in those moments.
Yeah.
And once I got there, then I could talk about and think about things in a new way. But that
Yeah.
was phase 1 of my journey of healing from his loss, was just getting to a place where I could be present again with people.
Yeah. I don't think that's uncommon, and I think that's actually pretty healthy.
Yeah.
But first, I worked with a mother who lost her son, and she's got 3 very successful, healthy sons, but one took his life. And I worked with her for 8 years, and she was a bad mother. That was her scarlet letter, that I'm a terrible mother because my son took his life. Even though her other sons did well, and she was a grandmother and had lived, was married for many years. I just couldn't get her dislodged from that notion. It became how she knew herself. And that was heartbreaking to me because she was so much more than just the mother of someone who lost a son to suicide.
Yeah.
But then who am I to judge? If I
Right.
were to lose a child to suicide, I can't imagine how I would go on. So I try to have like therapeutic or thoughtful ways of sort of approaching this and try not to judge because it is a horrible way to lose someone. There's just no question about it.
Yeah. You mentioned how would they have wanted you to live your life, and my brother is the person who introduced me to so many things. He was 10 years older than me, and it's very strange. I am now I have been for a while. I'm at an age where I'm older than my older brother ever was,
Yeah,
which is
yeah,
a very I have far more gray hair than he had. He never had gray hair. It's a strange place to be. But he introduced me to technology. He introduced me to science fiction. He always encouraged my love of psychology and all of these things.
yeah,
And I, after he died, and years after he died, I got to a place where I started wearing more T-shirts that communicated my love of Star Trek and this kind of
yeah,
stuff. I
yeah,
started doing this, and I can do video because of how comfortable he made me with technology. I
yeah,
speak at like Comic Cons and things like that about mental health and pop culture. And these are all ways that I feel like my brother would be proud of me.
yeah. That's
And
exactly what I'm
these,
talking about.
yeah, it's these are very
I
small
would say you're
ways.
honoring his memory.
Yes.
You're honoring his legacy,
No, I have,
which
you
is
know,
more than how he died, Ali.
right. I mean, I've got these little Star Trek reminders all over the place because that was I have cherished memories of how he introduced me to all the stuff, and we would stay up late talking about all these things and what they mean. It took me a long time to get there, but
Yeah.
I think that's a journey for a lot of survivors of suicide. Let's zoom way out, Dave.
Okay.
We've talked about individuals a lot. I want to talk about society and big picture. There's a lot of discussion happening right now about the mental health crisis of young people, of
Yeah.
teenagers, Gen Z, young adults. You've talked about how suicide rates have been going up, other causes of death are going down. What do you think is going on here? I'm sure it's not just one thing, but you've seen this also in the armed forces. You've
Yeah.
worked on really big scale stuff, rolling out these things in the Air
Yeah.
Force. Let's go big picture. What's happening, Dave?
There's a lot going on in this space. We had a drop off of suicides in 2019, 2020, and then it spiked back up after we were thinking, oh, we're on a downward turn. What has not dropped is anxiety, depression, suicidal ideation. I try to make a poignant point of this. We have 15.6 million Americans with serious thoughts of suicide on one SAMHSA survey in 2021. That's like 300 times greater than the number of people that die by suicide. It is the iceberg of the suicide problem. And what's interesting about that is I've had papers rejected from a clinical trial where we only reduced suicidal ideation and not necessarily attempt behaviors. So the field has this bizarre behavioral focus. I'm not against that at all. But the bigger problem is one of ideation with 15 million people. So that is very concerning. In the UK, you can get DBT, but only if you make a suicide attempt. Otherwise, in the NHS, the National Health Service, you get supportive counseling. So my friends there are saying, that patients basically are being operated conditioned to make an attempt so they get actual proven treatment.
Right. That's how
So
we're training people. Yeah.
it's a crazy situation. And then what we know from the more recent data that you alluded to from the CDC is that young people of color, young women in particular, but also black teens, I mean, that we are seeing the death issue has been with middle-aged white males. Like I said, 3/4 of our deaths. But the white males are coming down, and now young people of color are bumping up, and that's really concerning. And frankly, the research has been blind to color. So we have a specific study that we're doing with Sean Joe in St. Louis with black teens. We're trying to get LGBTQ plus teens because those are completely unstudied treatment populations, and we're trying to sort of change that. What I find fascinating is every week I watch videos for a clinical trial with teenagers and a clinical trial with college students, and we're going to do a clinical trial with children. But I get to hear what kids are wrestling with these days. These are pandemically affected kids. I've never before heard in my career, I'll never own a house as a reason for dying. I've never before heard people saying the earth is dying. I've never before heard of a young nursing student saying racial and gender oppression is my daily reality. These social determinants are really, at least anecdotally, and we're studying it, different. Back in the day, when I was first working in a university counseling center, we saw depressed college students. Now, it's 90% plus anxiety, very little depression. At least in the practicum I'm teaching this semester in the counseling center, it's all anxiety. It's mostly social anxiety. So it's I find it pretty alarming. And my sons are 25 and 27, and we talk a lot about this and about the generational aspects of this, and that their issues around social and economic equity that we talk about in depth. It's pretty considerable.
Yeah.
So.
There's so much criticism of kids and their smartphones, right?
Yeah.
And one of the best responses to that I've heard is, well, what kind of world have we built for kids to look up to look off their screen and to be plugged into?
Yeah.
And it's we have a lot of big problems that we're facing as a species, and these are not easy to solve problems. It's quite concerning. The other thing that I'm very concerned about is one of the reasons why I've started focusing on this kind of show where we're going deeper into these topics. There are less opportunities for young people to connect outside of school.
Yeah.
Those third places, which for my generation was more like malls and parks and things like that, culture has shifted, and the opportunities for being involved in those to spend time physically together have gone down. And that really concerns me. So much of what we've been talking about is relationships, connection.
Yeah.
It seems like we're so digitally connected, but it is harder to be connected IRL in real life. Last question for you.
Okay. I could do this all day.
I know I could too. I'm gonna run out of film. I mean, I record this digitally. I'm gonna run out of space here if we keep going. This care package.
Yeah.
What are the 5 things everyone should put in that care package for someone they care about?
Well, they should put the National Lifeline number, which is 988. They should put the National Text Line number, which is 74. You text home, the word home, to 741-741. I would put up a listing of all the key links for the American Foundation for Suicide Prevention, for Suicide Prevention Resource Center, for the CDC. We taxpayers have paid a lot to create resources for the public to learn about this. The CDC has a toolkit for youth suicide prevention that's very well crafted. I would absolutely include Tom Ellis's book called Choosing to Live as a very, very respectful, meaningful engagement for people that are thinking about suicide. Have you thought about this? Have you thought about that? And I would write a heartfelt letter about what this person means to you and why their life is so important to you, and that you would do anything that you could to help them if they would, if they'd be willing. Those are my 5 things. And I think And then you gotta, or I would argue one has to then sort of say, I've done what I can do. I've I've left it on the field, so to speak. I've really made every effort I can make as a sentient being, with limited influence over another person who's separate from me, one I care about very much. As a clinician, this is what I have to do, is recognize the limits of my influence. But I have a lot of influence, and I've got a way that's going to be, more times than not, usually effective.
Yeah.
But I can't make this person not do this horrific thing. And there's suffering involved. And so, in an odd way, Ali, to be honest, I become much less preoccupied with preventing suicide deaths writ large as sort of like an absolute idea, and much more focused on suffering and decreasing suffering in the world and decreasing the suffering in this person's life. Because to suffer in such a way that you think ending your life is the solution is a horrific place to be. And that's what our intervention and my work as a clinician, as a professor, as a teacher is really focused on, is that suffering and trying to decrease that suffering in the world.